Hello, everyone. Thank you for joining in this session. My name is Yumura, and I'm chairing this debate session. I look forward to working with you. This session is debate by Professor Shiraishi and Professor Amasami. And the theme of this session is NOA and varicocelectomy, treat or not. I'm sure you have all wondered on an NOA patient with varicocele whether we should perform micro-TC or you should perform varicocelectomy before performing micro-TC. And there is a hope that sperm may appear in ejaculate after varicocelectomy. I and you also have always wondered about this issue. Today, Professor Shiraishi will speak from cons position, and Professor Amasami will speak from a pros. Okay, the first, I'd like to start Professor Shiraishi. よろしくお願いします。
Thank you for can you hear me? Okay. Thank you for your introduction. I'm glad to be here and to discuss with Dr. Amasami regarding to the varicocele repair prior to micro-TC. It's a time for us to think about we should do all the patients for varicocelectomy prior to micro-TC. My standpoint is against. I have no COI in my presentation. So this is a very simple figure explaining the pathophysiology of varicocele. We don't know for each patient. We don't know where we are there. If the patient stand around here, we can expect varicocele repair will be beneficial for patient. But if we are here, no beneficial for the patient. To overcome this, there are some nomograms to evaluate the best candidate for varicocele repair. This is one sample reported by Marie Samprasky regarding to predict the effect of varicocelectomy using usual clinical parameters. This is a good nomogram itself, but also it provides a very good information because these parameters is a very bad predictor for this one. These parameters are bad for varicocele repair. And also, there are many good urology experts here. Let's talk about the efficacy of varicocelectomy in these guys. These guys are same parameter as a hormonal abnormality, but everybody can easily imagine which guys will be beneficial for varicocelectomy. Of course, this guy. So I also make my own nomogram using including FSH level and BMI and comorbidity. It's very similar with Marie's nomogram. And also, this parameter is also a very bad predictor for varicocele repair. So these guys are located here. In case of NOA, Azoospermia is a very bad predictor for the predict the effect of varicocele repair. So NOA is located here because there may be many other causes in case of NOA. So many patients, we can easily diagnose varicocele for infertile patient, but it's very difficult to differentiate which patient should do varicocele repair in case of NOA. So this is a questionnaire-based reports from Global Andrology Association. Around half of the experts do not recommend to do varicocele repair prior to micro-TC, and if they recommend varicocele repair for younger female partner, normally FSH, and ipsilateral smaller testis, and large varicocele. But around half of the experts do not recommend varicocele repair prior to micro-TC. So effect of varicocele repair prior to micro-TC remains highly controversial. So this is a good review for the ejaculated sperm to predict ejaculated sperm after breakthrough repair based on categorized by testicular histology. So in case of cell-to-cell only SCO, we cannot expect high sperm appearance after breakthrough repair, but in case of late maturation arrest, we can have the patient have ejaculate sperm. But totally, as majority of NOA patients have SCO histopathology, so we can't, majority of patients do not have a chance for ejaculate sperm. So let's, basically, I have performed breakthrough repair for me, but all the cases who have NOA and palpable breakthrough. So it's a time to consider the efficacy of breakthrough repair using ejaculated sperm and the situation with microtesserae. So let's talk about the situation for ejaculated sperm. So this is my own 83 cases of varicocele with NOA, the patient age, and also this is truly NOA, and the testosterone is a little bit lower. So I categorize, oh sorry for the color. I categorize the past histology. So in case of SCO, only 2% of patients have post-ejaculated sperm after breakthrough repair. And on the other hand, if the testicular histology is hypospermatogenesis, we can expect around 70% of ejaculated sperm after the surgery. And totally, 24% of cases have ejaculated sperm after breakthrough repair in my case. And also, surprisingly, the reproductive outcome is only 6%. It's not surprising. It's surprising because we can't see any beneficial effect in terms of reproductive outcome. Sorry for the color. And in case of ejaculated sperm after varicocele repair, the distribution of sperm concentration and total sperm count is shown here. So this case we can expect for non-ALT treatment, but in this case we have to use ALT. So only 2 cases, 10% have natural pregnancy, and also including IUI, only 3 cases, 15% could have pregnancy after varicocele repair. So remaining 85% of men needed IFFS, and the most important problem is wife's age. Wife's age at first IFFS was 37.9 years. It's a little bit higher compared to normal the patient of wife's age. So results of 70 ALT cases. Overall pregnancy rate is 47%, and the mean oocyte retrieval, the number of mean oocyte retrieval 2.8 times, and overall live birth rate was 24%. But importantly, testicular histology at varicocele repair, I always do testicular biopsy at varicocele repair. The majority of them are hypospermatogenesis and late maturation arrest. So these guys, we can retrieve many sperms without varicocele repair. So this is a nice review, nice review regarding to varicocele repair and of NOA. This is they have totally 34% ejaculated sperm after varicocele repair. It's a little bit higher for our experience compared to our experience. And also natural pregnancy was 4%, and with the out pregnancy was only 20%. It's not the reproductive outcome of these numbers are not very satisfied. So in case of situation, when we use microtesserae, so we call this as persistent azoospermia. So in case of persistent azoospermia, let's go back to testicular histology again. So this is my current series of NOA varicocele, total number 131. His pathology is like here, and ejaculated sperm is 15%. And in case of microtesserae, I could retrieve sperms out of 36% from the patient. So this number is very similar without varicocele. So this is a reproductive outcome. The number of oocyte retrieval and clinical pregnancy and live birth rate is similar between the groups. This is a conventional IVF efficacy during the same duration. Let's see this one. The ages of patients and their wives are significantly higher than the others, indicating that we can lose the chance for wives treatment. So 3 meta-analyses are reported regarding to these topics. This is one example. 3 RCT shows the significant increase of sperm retrieval by microtesserae, but all 3 meta-analyses does not have any clinical benefit for clinical pregnancy and live birth rate. And also, this is another RCT. There's no any benefit for clinical pregnancy and live birth rate. So as a result, AUA and EA guidelines do not recommend prior varicocelectomy for NOA patients. So even the results of past RCTs may be fundamentally challenged. A majority of the report did not indicate the number of methodology and the number and the methodology of semen examination, meaning that Dr. Schlegel indicated that by centrifuging the sperm samples, they found 9.6% of sperms in the pellet. So he is very against about prior varicocelectomy because he can obtain this percent of sperm, ejaculated sperms, without varicocelectomy and do the similar result or similar reproductive outcome by using ICSI. So let's talk about the genetic aspect. So in the advancement of sequences, the number of genes contributing the pathophysiology of NOA is increasing. So this is an updated genes percentage. Karyotype abnormality and mutations are reported about 27%. And also, this number is also increasing, and up to 40% of NOA patients estimate to have genetic diseases. So in this case, around less than half patients have genetic disease, indicating that there is no benefit for varicocele repair. So we can't forget about the bad side of varicocectomy. There is some complications. This is a series of my 2000 cases of microsurgical varicocectomy, and the recurrence rate was 0.25%. Hydrocephalus and hematoma was 0.05%. It's not 0. So I think varicocele associated azoospermia will be called as VAR. So NOA varicocele exists, but we have to estimate and determine who is a varicocele associated azoospermia. So let's go back to the histology again. So this hypospermatogenesis and late maturation allows patients very easily to respond to varicocele repair, and so we should call this as varicocele associated azoospermia. So it's up to 39%. So this is my transcriptome analysis using human testicular samples. By seeing this, a number of some cell cycle-related genes are involved to the response of varicocele repair to predict ejaculated sperm. So this is a PCNA immunostaining. This upper patient have very good ejaculated sperm after the surgery. On the other hand, this patient has no sperm called as persistent azoospermia. So this is a big difference. So in case of downregulated genes, some antioxidant genes are reported, and these patients have good response to varicocele repair, indicating that varicocele repair can improve testicular oxidative stress. So this is a very simple report regarding to the varicocele grade and the response to the surgery. So large varicocele grade are easily to respond to varicocele repair. So what is VAR? This slide summarizes what is VAR. So with large varicocele and histology, hyposomagenesis or late maturation arrest, active spermatogonial proliferation, vulnerable to oxidative stress, younger age, low FSH, volatile case. This is some reports support this. So this is not scientific conclusion. My impression is 10 to 20% of NOA with varicocele will be estimated as VAR. So lastly, we have to mention about insurance. Microsurgical varicocele repair is covered by Japanese insurance. So patient should pay only $250 for varicocele repair. This is good for patient, but we have to make evidence to provide the government. So in conclusion, so I'm standing at the varicocele repair should be all cases against cons. So because the reproductive outcome is not favorable, and also RCT is not low quality, and also but in the future we have to clarify the patient what is VAR as a non-invasive manner. Thank you very much.
Thank you, Dr. Shiraishi. Back to the seat, your seat. Thank you. Hi. Professor Shiraishi spoke from a cons position. Next, Professor Masami, consultant urologist at Jumeirah's American Clinic and First IVF Dubai, will speak from a pro position. Varicocele recommend. Please start speak.
Thank you. Good afternoon, everybody, and thank you for attending this talk and great talk by Professor Shiraishi on varicocelectomy to be not done for men with non-obstructive azoospermia. I'm going to speak from the pro position of why we should do varicocelectomy in patients with non-obstructive azoospermia. We are not talking about obstructive azoospermia. This is specifically azoospermia due to a production defect. So non-obstructive azoospermia, you have to classify the patients very well. If you do varicocele repair in patients with obstructive azoospermia, you're not going to get a good outcome. So these are men who don't make sperm because they don't produce enough sperm. Varicocele, we talked about different grades of varicocele, grade 1, 2, and 3. I think we all agree that both grade 2 and grade 3 clinical varicoceles will make an impact. Subclinical varicoceles, the ones that are diagnosed only with ultrasound, probably will not make an impact in these patients. So today's position is, should we consider varicocele repair in patients with azoospermia? So what is the biological rationale? Why should we think about varicocele affecting sperm production? Professor Shiraishi mentioned 10 to 20% of these guys will have varicocele-associated azoospermia. Elevated temperature, oxidative stress, hypoxia, right? All reasons that can impact sperm production. Varicocelectomy may actually improve the microenvironment within the testis to actually stimulate sperm production. So what are some of the benefits of doing varicocele repair in patients with non-obstructive azoospermia? He showed some studies, and I think we all do know, that about 30 to 50% of men can actually have sperm back in the ejaculate. I think we're all very clear. These are patients who come to our clinic with zero sperm. not few sperm, not 1 million sperm, but 0 sperm. If we give them a chance, a 30% chance, let's use the lower number, of saying we are going to get some sperm back in the ejaculate, I think that's much better than 0%. Because the chance of, yes, IVF clinics and embryologists using ejaculated sperm will now go from 0% to 100%. And we also provide them the small percentage of natural conception. Because the chance of natural conception in a guy with 0 sperm is 0%. The chance of natural conception in a guy with a few sperm in the ejaculate is at least 5 to 10%. So for the patient, even though the chance of reproductive outcome is low, it is no longer 0. So I think we should understand that varicocelectomy can benefit a small subset of patients because it can afford the small chance of natural conception. Very nice study from Japan here, showing men with clinical varicoceles and non-obstructive azoospermia. There is a chance of reappearance of sperm in the ejaculate. I think we discussed that to be about 20 to 30%. It can enhance Leydig cell function. A lot of these guys with azoospermia due to production defect can have low testosterone levels, and improving their varicoceles can improve serum testosterone levels that can enhance libido and functions of testosterone deficiency. And some of them can still have persistence of azoospermia. For those, we can consider microtesy about 6 months later. So what happens if there is no sperm back in the ejaculate after you have done a varicocelectomy, and now you do need to go on to do microtesy with IVF? Very nice meta-analysis that basically shows that there is an increase in the chance of live birth rate for those who have varicocele repair prior to their microtesy. So varicocelectomy seems to improve something within the testicular microenvironment. We still don't know the exact mechanism that supposedly improves the chance of finding sperm and finding better quality sperm that can be used for assisted reproduction, that can improve their IVF and ICSI outcomes. The EAU and the AUA guidelines actually recommend against doing routine varicocelectomy. I do not disagree with them. I think they are correct. However, there is a small percentage of men who have varicocele repair and then have sperm appearing in the ejaculate. And I think we, as urologists and doctors, need to identify that subset of patients that will improve in their sperm outcomes after varicocele repair. It's a nice meta-analysis of about 11 studies showing sperm appearing back in the ejaculate in about 40% of cases. Even in those couples that did not have sperm back in the ejaculate, people who had microtesy after had a higher chance of sperm retrieval than those who did not. And varicocele repair does seem to improve testicular function. A nice picture here showing the veins clipped off and the artery here spared in the middle. So what are some of the predictors of success? You do a varicocele repair, you do a testicular biopsy, preferably at the same time. What are the chances that you will tell the patient sperm will come back in the ejaculate? I think we discussed that having hypospermatogenesis, small foci of sperm production within the testis, will have a higher chance of finding sperm back in the ejaculate. Even though a few tubules can make sperm, but they don't have the ability to make it sperm back in the ejaculate. However, doing a varicocele repair will now enhance these few tubules that make sperm within the testis to push the sperm out in the ejaculate. So it all really boils down to patient selection. Who are we going to choose and decide who to do varicocele repair on and who not to do it on? First and foremost will be female age. If the female partner is young, without female factor infertility, and they have time according to the ART specialist to wait, then that is a good patient to think about doing a varicocele repair on. If the female has advanced maternal age, poor ovarian reserve, endometriosis, PCOS, anything that would impair ART and time, then asking that couple to wait 3 to 6 months after varicocele repair, probably not a good idea. you have to think about having a clinical varicocele, not just an ultrasound report showing varicocele, but a urologist examining the patient and saying that he has a grade 2 or a grade 3 varicocele, normal FSH, or just mildly elevated FSH, young patients without significant comorbidities. Professor Shirashi showed a very nice picture of a young guy who does not have obesity and comorbidities versus an older male with lots of comorbidities. I think clearly that young patient would respond better to varicocele surgery than that older patient. And of course, if you have a previous biopsy report showing late maturation arrest or hypospermatogenesis, I think those patients will have a very good chance of finding sperm back in the ejaculate. So let's discuss this patient scenario. Who is the ideal patient couple for undergoing varicocelectomy with azoospermia? So it's a young male, 32 years old. A partner is 30-year-old female. She's young. She has normal reproductive evaluation with normal AMH and uterine scan. Clinical findings, they've been trying to conceive for the last 2.5 years. Azoospermia has been confirmed on multiple sperm analyses. It's been centrifuged, and no sperm has been identified on both the sperm analyses. On physical examination, there is a palpable left grade 2 varicocele. So it's a clinical varicocele, but it is unilateral. And the testis size is about 12 cc. So normal testis size is 16 to 20 cc, and 12 cc testis is little small, but not atrophic. On the hormonal profile, we see an FSH level of 9.8. So it's mildly elevated. The LH is about 6, and the testosterone level is within normal limits. The ART specialist has examined the female. There is no evidence of ovulatory dysfunction, tubal pathology, or endometriosis. As a show of hands in this audience, how many of you, raise your hands, would fix the varicocele in this couple? It's a tie, it's 50-50. Good, there's room for debate. Okay, so what did I do? I fixed the varicocele in this couple. The 3-month post-op sperm analysis showed 0.36 million with 0% motility. So we went from 0 on 2 sperm analysis. At the 3-month post-op, we had 0.36 and no motile sperm. Couple very disappointed. They said, oh, we thought we were going to get sperm back in the ejaculate. Let's see if we can wait. 6 months later, now the sperm analysis became 4 million per cc and 11% motility. They did not want to wait any longer. They didn't want to try for natural conception. So they went ahead with IVF. And IVF lab was very happy to use ejaculated sperm. They were motile ejaculated sperm, much better than rare testicular sperm obtained with a microtesy. So they used the ejaculated sperm and did IVF. And they had a pregnancy in 12 months. This is AI ChatGPT generated, but it became a happy Japanese couple after the varicocele repair. So I think it is all about patient selection and picking the right patient. I think if we say one treatment can be applied to all patients, we are going to be wrong. If we say one treatment and say we're not going to do it on any patients, I think we will still be wrong. I think we should pick and choose the correct patient, and in this case, infertility, pick the correct couple, because female partner evaluation is extremely important to decide what we do on the male side as well. Dr. Shirashi discussed a lot about risks and benefits. His risk of varicocele surgery was less than 0.025%. I think getting into a car accident walking in Japanese roads will be higher than 0.025%, and so the risk seems very, very low. It is a very safe operation, and we do have to consider, obviously, hydrocele and risk of recurrence, but I'm fairly certain that if you tell any patient the risk of surgery is 0.025%, they'd be very happy to sign up for the surgery. There's lots of benefits to varicocele repair. You can have the return of sperm to ejaculate. It is definitely less invasive than needing to undergo a microtesy. Patients get very scared of microtesy and long-term hypogonadism. So even if you can avoid microtesy in 30% of the patients, I think patients will be very happy to undergo varicocele surgery. And they may not need to do ART right away. Because if they have 0 sperm count, the only chance they're going to have a child is through microtesy and IVF. But if we tell them we fix their varicocele we can give them a small, I am not saying this is very high, a small percentage chance of having natural conception, I think they would much rather go that route than needing to go to IVF right away. There's a very nice study that was quoted and about varicocelectomy and azoospermia, and about 39% of these patients actually benefit. So this is Professor Shirashi's own data, and he showed it very nicely. But my interpretation of this data is a little bit more optimistic than a very pessimistic view of the data. If you combine 24 plus 15, that's about 39% of patients that actually benefited from having a varicocelectomy for non-obstructive azoospermia. 39% versus 0%, I think 39% is a very good number. He's a very good surgeon and therefore had very good surgical outcomes in this series. So I think I'm in complete alignment with Professor Shirashi. He's an expected expert in the field and has actually published findings that support the varicocele repair in patients with non-obstructive azoospermia. I think his paper is very important. It actually outlines those with clinical varicocele, bilateral, with focal areas of hypospermatogenesis or late maturation arrest to support that we do need to perform varicocelectomy in that specific subcohort of patients. So I think this aligns very well with my position, that varicocelectomy actually improves outcomes in select patients with non-obstructive azoospermia. So in conclusion, I think varicocele repair definitely offers a potential fertility option in selected patients with non-obstructive azoospermia. I am not recommending varicocelectomy for every couple with azoospermia that walks into your office. I think we have to choose and pick and choose the correct couple. And I keep repeating the word couple and not the patient, because we need to include the female partner in this equation. Older female, female factor infertility, blocked tubes, advanced maternal age, premature ovarian failure, low AMH. We shouldn't be trying to do varicocele repair and waiting 6 to 9 months. We should think about microtesty and IVF. We have a young female with no female factor infertility, with good ovarian reserve. We should definitely think about fixing the male partner and giving them the time to make sure that we do have a small percentage to get sperm back in the ejaculate. We should not universally apply this to everybody. As I said, we should pick and choose the correct couple. And I think there is enough evidence, as published by our colleagues here in Japan, showing that there is consensus and evidence that actually support the pro position. There are very few studies that provide anti-position, but lots of good, well-done studies that support the role of varicocele repair in patients with non-obstructive azoospermia. And I think we deal in a field, especially in a conference like IFFS, where we see several gynecologists coming together with urologists and embryologists to have a multidisciplinary discussion. Is this the right option for the patient? What are the couple's expectations? Do they want to have a child right away? Can they afford and want to do ART right away? Would they like to wait and see if there is improvement of sperm counts in the ejaculate or not? I think lots of questions need to be answered, and I would strongly favor a multidisciplinary discussion with the ART specialist and the wife and the patient together, and then decide what the right choice is for this couple. I'd like to thank you all for the opportunity, and we welcome any questions later on. So thank you.
Thank you, Professor Ramasamy.
Very nice hospitality.